All right, so welcome everybody to the Clinical Consultation Network. As you can see, I am not Dr. Bruce Davis. I know we look very similar, but I'm Michelle Bagby. I'm the Director of Behavioral Health and Crisis Services for DIDD and the 10 Start Director statewide, filling in for Dr. Davis today on the Clinical Consultation Network. We do this every Tuesday at 12:30 Central Time. We have upcoming guests, but TBD on who they are, because we don't have our intro slides today. So we are flying by the seat of our pants a little bit, but we'll be just fine because we've done this a lot and it's okay. So we're going to skip our Smarticle and we're going to dive right into the amazing presentation that we have. So we have Dr. Beth Malow here today, who I'm going to let introduce herself and share her fun fact. And then she's got a few other team members with her that are going to jump in too. So I'm going to hand it over to you, Dr. Malow, and let you take it.
Sounds great. Well, thank you so much for having me. We really appreciate this. I am at Vanderbilt. I'm a neurologist. I specialize in sleep disorders, but I also have done a lot with autism. My two sons are on the spectrum, and I've kind of watched them grow up and have been involved initially in sleep and autism in kids, and now more in adult healthcare for autistic adults, and getting people trained in the community, doing work with self-determination and engaging people in research and making sure we listen to the stakeholders' voice, the family voice, the self-advocate. And the reason I'm here today is to tell you about a ECHO program, and I'll explain what ECHO is if you don't know what it is in a minute, that we're really excited about. But first, my fun fact. I am a performer. I am a singer. During COVID, though, I decided to not sing in crowds and groups because of the risks, right? And I channeled my energies into public speaking. Now I am president of my Toastmasters Club. Toastmasters is an international speaking group organization, and we have multiple chapters in Tennessee, including my chapter, which is called Brentwood Early Risers Toastmasters. So if anybody wants to hear more about that, you can message me. I think it's a fabulous way to learn how to become a better public speaker, a better leader, and I've really embraced it fully. And it's helped me with my presentation today.
It's such a good pivot from singing and something you can use in so many formats.
And I hope to get back into singing. My synagogue choir, I'm going to start by singing with them again. I used to sing with Sweet Adelines, the a cappella barbershop women's group, and maybe someday I'll get back into that as well. We'll see. Now, do you want it, Michelle, do you want to ask me some questions first, or should I
No,
show some
I don't have any
slides, or
questions,
what do you
but
think
can
is
you
best?
introduce your other two
Yes,
possible co-presenters?
absolutely. So no pressure on Janet and Sally, but I'm very thrilled to have them with me today, and they may jump in and answer some questions as we go along. We have Janet Schaus, who many of you already know from the Vanderbilt Kennedy Center, and she's helping us with this project. And then also Sally Fukawa, who I don't see on camera just yet. Sometimes she needs to be off camera for her bandwidth. And she is another coordinator at our Vanderbilt Kennedy Center who's helping with this project.
Absolutely. And we're happy to have both of you here as well. Haven't had the opportunity to meet Sally yet, so welcome, Sally. Janet is probably one of the most loyal CCN attendees in all of the state. So we know her very well, and she is a great partner in everything that we do. So happy that you're all here today.
And I think do you have my flyer, Michelle? We can put that in the chat, Sally, maybe if you can make the chat work. We just
We'll
wanted
make
to
that
make sure
happen.
everyone knew that one of the thrills about coming on today's CCN, thank you for having us, is that we're about to launch this new program and in September, and wanted to make sure everybody knew about it and also knew how they could get involved, what the criteria were, all of that. We will try to get something into the chat. If not, maybe we can send something out, Michelle or Babs, afterward.
I am about to drop them in right now.
Yeah,
Oh,
they'll be
yes,
in the chat.
fantastic. Thank you. Great. Great. So Michelle, did you want to ask some questions to get us started, or should I show my slides, or what? I'm flexible.
Whatever makes you happy. I mean, I would definitely start with, I think, for people on who aren't familiar with Echo, just kind of starting to talk about what that is. And I think it would be good to share too. This isn't the first Echo program you guys have done. Maybe sharing some of the previous topics that you guys have covered would be helpful too.
Absolutely. Yeah. So let me go ahead and start, and then I'll pull up the slides as needed. I prefer to just have a conversation. So feel free to raise your hand if you have questions along the way. Basically, ECHO stands for Extension for Community Healthcare Outcomes, but I like the acronym ECHO beyond that, because to me it's echoing or reverberating, or thinking of throwing a rock in a pond, a pebble in a pond, and seeing those circles going out. I think of it as transforming information in a way that we can all benefit from it. And the way the ECHO model works, let me start out by saying it was established, invented, created back in the early 2000s by someone named Dr. Sanjeev Arora in New Mexico, because what was happening was he was seeing a lot of patients with hepatitis C, and there weren't enough doctors to treat them all. So he said, what if I could develop a learning community where I could help other doctors and healthcare professionals learn about hepatitis C and how to treat people and how to use best practices. And then they could do that in their communities. It would be so much more efficient and effective than my seeing all these patients on my own. And that was the birth of ECHO. And it's since expanded to, I believe, every continent, maybe not Antarctica, but like every other continent. Just about every condition, whether it be seizures or chronic pain or epilepsy. We even have had multiple COVID echoes to help treat COVID during the pandemic. We have several in autism and IDD, and they've also expanded beyond primary care to various other things, like helping families be part of treatment and support. They've helped in education with, we have a reading echo at Vanderbilt that helps people with dyslexia. So we've really gone beyond, but the model is the same. And basically what the model is it's people coming together like we are. It's done on Zoom. Zoom is the platform that ECHO partners with. But it's basically where we all get together, and we have, it revolves around a case. So somebody will present a case. For example, a primary care clinician will present a case, and then all the other people on the ECHO will listen to the case, ask clarifying questions to get a better understanding of what's going on. And then they, as well as expert members, will give recommendations. And these expert members are not just physicians, they can be family members, resource connectors, navigators. They can be self-advocates. Every time we do an ECHO, we try to include family members as well as people with that condition or that issue, to get their lived experiences. And then we sometimes also have what's called a mini didactic or a short learning session. And then the echo concludes after an hour to an hour and a half, depending on the echo, and we send out resources. Most echoes meet for several months, at least twice a month, sometimes more often. And by the end of the echo, our goals are to not only impart knowledge, we call it competence, right? But confidence as well as competence, the ability to say, I can do this, I can treat people with autism or with IDD in my community. I'm not feeling isolated because I know there are other people who are just like me, who are learning. I now know several psychiatrists. I now know several navigators, resource navigators. So it's really a very beautiful thing for increasing capacity. And that's our goal, because we all know, right, from the CCN that caring for people, especially adults with intellectual and developmental disabilities, clinicians are not falling off trees, right? I'm just looking at my tree background, to jump up and care for these folks. We need to do more training. We need to increase our workforce. So in a nutshell, that is what an echo is all about. And I'm going to pull up some slides, but before I go on, I just wanted to see if anyone had any questions on the echo model based on what I just presented.
Yeah.
Or if Janet or Sally want to add anything.
Yeah, I was going to say I have questions and comments, of course.
Yeah.
So, I mean, first of all, I think it's a really amazing concept. I mean, it's all about capacity building, sharing experiences and knowledge on a global scale. It kind of feels like grand rounds, but like on a much larger capacity, which I really like that aspect. How do you what goes into determining what the topics that need to be covered in an echo, like the theme of the echo, like what goes into that process?
Yeah. So there's you can think of the topics in two different ways. One is the actual case that's presented every time. And we really do put a premium on case-based learning. That's how we learn. And that oftentimes is driven by the presenters. We give them a lot of latitude. So if the goal of the ECHO is healthcare in adults with intellectual and developmental disabilities, chances are good it's going to be how do I manage psychotropic drugs? How do I manage obesity? How do I manage behavioral issues? Whatever. So that's a lot of it is, what are the goals of the ECHO? Many echoes, including ours, are associated with continuing education, continuing medical education, continuing education for psychologists. That is oftentimes going to drive the echo as well, because we'll have learning objectives that we'll want to satisfy. But the other big piece, in addition to the case, is those mini didactics I mentioned. And those oftentimes go beyond the echo. In fact, this is where I will pull up a slide. Just bear with me, because these are slides I had put together, not knowing I was going to show slides for an echo presentation tomorrow. So they really wanted to know, for example, who was going to be presenting each week. So that's why I have these lists, and some of them have TVAs. But this is going to give you a sense of these mini didactics. So in addition to things like managing medical conditions or managing psychiatric symptoms, we've got things like supporting adults with IDD during clinic visits in your practice, or enabling technology, including assistive communication devices, or self-determination and life skills and social supports, or relationships and sexuality. So you can see that the topics actually go beyond the medical and behavioral health type topics into some of these topics that really deal with the whole person. And these are presented in 10 to 15-minute segments at the end of each of our echoes, keeping in mind that many of these will work their way into the case itself. But the cases, we give our presenters a lot more latitude and flexibility. They don't have to stick with these topics, for example. So for example, if we're going to be presenting management of medical conditions in adults with IDD, it doesn't mean that the topic that week has to be medical conditions. It's just that we want to cover these topics, these mini didactics within our ECHO curriculum. We stop these for a moment, then I'll come back to them a little bit later.
The other question that came up for me is one, I mean, I feel like knowing how it is to organize events and learning forums like this, how much prep work goes into kind of the establishment of the ECHO and the didactics? And is that something that you guys have got a good rhythm for as you're creating these?
Yeah, and actually, can you help me figure out how to get
Yeah, I'll
out of
take it
this
from you.
stuff? That'd be great. I apologize, just so that we can all see each other. Thank you. Great.
Beth,
Thank you for
can I
doing
jump
that.
in just a minute to
Please,
respond a
Janet.
little bit to Michelle's question about how do we
Yeah.
determine the topics? Part of it is we have this team that we call the hub team, which is our experienced, we used to say experienced clinicians, but it's beyond clinicians now. So it is people who have dealt with, in our case, adults with intellectual and developmental disabilities, and those experienced clinicians know what the issues are that come up in their clinics and the patients they see. So the things about, psychiatric conditions are more prevalent, so we need to address those. Certain medical conditions are going to be more prevalent, and there may be ways we need to handle those that you wouldn't with a typical patient. But then also some of them are coming from families and individuals themselves who say, I went to the doctor and he never mentioned anything about possible employment resources or post-secondary options. And so we hear the clinicians need information about these other kinds of resources, not just how to improve their medical care, but how to improve the lives and the quality of the lives of the people that they're seeing in their clinic. So it's a combined effort for how we determine what are the key things that we have in these mini didactics, these 15 to 20-minute sessions.
Yeah, that's very well put, Janet. In other words, it's the stakeholders themselves,
Yeah.
the community, nothing about us without us. We want to make sure that we're being responsive so that the things that adults with IDD and their family members care about actually get taught.
Yeah. Do you do any kind of surveying of participants on, topics that they need help with too, like throughout the process?
We
Like
do.
to help inform like future ECHO or that same one particularly?
We ask a lot of questions. In fact, all of the echoes that I've been involved with have included surveying and assessing, both with forms as well as with open-ended type questions or interviews, because we really want to learn, and we've published as well. I sent around earlier a paper that we just got published. If you want to learn more about the ECHO model, we were funded by the Department of Defense to do a national ECHO on adults with autism, or people who care for adults with autism, clinicians. And the results of that study, including the results of the surveys, are now published. So barriers, what kinds of barriers do they encounter? What did they get out of the program that was very positive? Those kinds of things.
All right, my other question is a little selfish. So what are you doing? So I think it's amazing that you guys are making poignant efforts to include people and families with lived experiences in all aspects of this. What are you doing to recruit those people, to get them involved in the process?
Yeah, good question. We, um, so two things. One is this is separate than the recruitment of the clinicians, which I'll get to in a moment. This is more when we've had stakeholder advisory boards, either through the current project or through the project that I sent the paper around for that will get out to everyone, or for a related project where we helped people with intellectual and with intellectual and developmental disabilities learn what research was about, learn how they could be part of research teams. The common thread is to really impart for people the importance of contributing in a way that will further our knowledge and make sure they feel like they're part of it and that they have a voice to contribute. So I'm going to actually speak more for what I did with our, we called it the ASSERT project. It was a patient-centered outcomes research project. Then for the current one, partly because of the time crunch, we've been working with our hub team and also a MERA group who's supporting and funding the work to actually do the planning. And that hub team, as Janet mentioned, includes not just clinicians, but self-advocates, family members, whatever. But when we do this more broadly, it's really, really important to us that we recruit people who can give us the patient voice, can give us, the family voice. And the way that we do that is we reach out to them and we meet with them one-on-one, and we tell them about the project. We hear what they have to say, what they feel their contribution could be, what they feel the needs are, or why it is important to reach out. That I think helps us because they feel from day one like they're contributing in a meaningful way, and we can also kind of impart why it's important. So we did one-on-one interviews with our stakeholder advisory groups for our last several projects.
I'm also going to jump in and say we've used the Kennedy Center Community Advisory Council, which is made up of people with disabilities, family members, and then provider and disability organizations that provide advice and consents to the University Center for Excellence at Developmental Disabilities at the Kennedy Center. And so one of the huge things that came out of that discussion about creating this ECHO was the need for better information about community resources, because the families and individuals didn't feel like their healthcare providers had any guidance to them about particularly what happens after the individual exits school. So that was a huge takeaway from that stakeholder group, was we need
Absolutely. Yeah, Janet and I ran
information.
that together, and it was a real eye-opener to us. That was really what people needed and really wanted, and felt like they just didn't know where to find those resources, and the clinicians were very much in the dark. And that's one of the reasons we're really excited about this ECHO, because it's focused on Tennessee. Our Department of Defense ECHO was more national, which was great, but it wasn't as focused on the specific resources. So we have that on this ECHO. We're focusing on Tennessee specific resources. And for example, we have Linda Brown from Pathfinder, Tennessee Disability Pathfinder. We have Janet, of course, helping with resources because she's so knowledgeable. And I really am excited to see how we can connect clinicians with community resources so that then they can connect their patients and family with those resources.
Are there specific objectives for this Echo that you're getting ready to launch?
Yeah, so our key objectives, and I can go back to my slides for just a minute, and then I can also tell you about our target audience. Let me share again. So our aims are right now, we're in the process of getting ready to launch. So we've been developing the curriculum and protocol, including what I showed you a moment ago with the different didactic lectures, didactic sessions. And then what we're going to do is we're going to implement it in 2 sets of 25 AmeriGroup clinicians who care for adults with IDD. And the reasons that we're going to do this twice is because, like anything else, when you do something the first time, you learn a lot of really important lessons. And then what we're going to do is we're going to regroup and reapply, do the Echo again next year. And that way we can make it even better. And that's the model that we used in the paper that we'll be sending around, the national Echo that we did. And then this is the really, really exciting, innovative part, I think, is we're not going to only look at surveys, but we are going to have access through AmeriGroup, which is one of the 3 managed care organizations affiliated with TennCare. We're going to be able to look at claims data. So we're going to be looking at body mass index. We're going to be looking at medications. Hopefully we can get our medications database going, ER visits, hospital admissions, even the number of mammograms that are ordered for preventive care, various other health care utilization. And the idea is to look at it before the Echo, like a year before the Echo in these different practices, and then look again after the Echo is done to see if we are able to move the needle on any aspects of health. So this is very new for us because most Echoes have focused on clinician surveys. Do I feel more informed? Do I feel more competent? Is my knowledge level of IDD better? Am I more engaged? But this is actually going to try to look at whether we've been able to make a difference with healthcare. And the answer is, I don't know. I mean, it's definitely experimental and exploratory because we don't really know if we're going to be able to make a big impact yet, but we wanted to at least try and look.
So will you be able
Those
to
are
pull
our
data
aims.
specifically from the participants, like the people who are cared for by the participants of the Echo? Is that what you're saying you'll be able to do?
Yeah, we're going to do it in a de-identified way. So it'll be aggregate. So it'll be each clinician's group of people with IDD. But yeah, I mean, that's the goal. So for example, if we're really hammering in the importance of diet, exercise, sleep for obesity, which obesity is, as many of you know, is one of the key co-occurring conditions that we really need to address in IDD, adults with IDD. Will our Echo make a difference? Will all of this teaching make a difference in terms of reducing obesity? Those are the kinds of things we want to get at. I also wanted to just show this early on in case questions come up. We are really being broad in who we're recruiting. Initially, our Echoes recruited primary care clinicians, physicians, nurse practitioners, physician assistants, but we're going beyond that to any clinician. So a neurologist, a psychiatrist could be included. We've had some interest, for example, from OBGYNs, and a lot of times they provide primary care. So we really wanted, for people, we really wanted to be broad. And then psychologists, licensed clinical social workers, really anyone who either is currently seeing or anticipates seeing adults with intellectual or developmental disabilities. And then the key is that they have to accept AmeriGroup insurance, because AmeriGroup is funding this with the idea that they're going to try to change the needle on the care that AmeriGroup is providing. And then we have 6 months, so 12 sessions total, the first and third Thursdays, starting in September at noon, and going for an hour. We decided, even though we could go for an hour and a half to 2 hours, we decided to limit it to an hour because everybody's so busy, and trying to do it over lunchtime. And to date, we've done very well. I think, Sally, we're up to, we've recruited about 8 people, is that right, or so?
Actually, about 12 as of today.
Oh, wow.
Yeah, very exciting.
Yeah, that's
You're aiming, you
great.
said you were aiming for 2 groups of 25, right? So you're going for 50?
Yeah, so we're gonna start with this first echo that's starting in September. We're aiming for 25, so we're about halfway there.
Can I
So,
ask, do you have any, like when you're like trying to measure the outcomes and stuff, are there any measures of, or maybe this is like a future studies kind of question, but like of the people served by those clinicians with intellectual disabilities, any like satisfaction survey or like kind of on their end, how they feel about the services they're receiving? I'm just
that's
curious,
a
like,
Really
great
good question.
We have thought about doing that. It's tricky because we also want
yeah,
to be careful. A lot of primary care clinicians, or clinicians in general, are sensitive to, I mean, they're doing the echo because they want to learn, but they realize they have a lot to learn. And the stress of being judged by the people they're serving, we wanted to be very careful with that. I mean, I think it's also challenging because we also don't want to create too much burden in terms of too many things we're analyzing and studying. But I think it's a great idea. I mean, I think we'll eventually
longer
get to that.
term.
I think we decided in this particular echo, since the claims data piece was going to be brand new for us, we wanted to focus on that. And then we're also adding kind of an innovative piece where each clinician is coming up with specific goals for themselves and their practice. For example, I want to make our office area more friendly to people with IDD. And then they're going to rate themselves before and then at the end of the echo. But the idea of actually getting patients and family members to rate how well their clinician did before and after the echo is definitely on our radar. We just haven't gotten there yet.
Yeah, no, I think that's a really good aspect to think about for the future, though, for sure. I was going to ask a question. It may have left me. Oh, I was going to say it wasn't a question. It was a comment. I really like that you're including people that anticipate working with this population, because I think that's such a big need. I mean, as you said, there's a shortage, right, of people that feel like they have the capacity to serve this population. So I like that you've included them as you don't already have to have, patients or clients or whatever their, role is. Established. So I really appreciate that you guys include that group, because it's that's what we need, right? We've got to
Thank
grow.
you. Yeah,
We've got to
that
grow the
actually
system.
came from someone who inquired whether we could include people who did not currently care for people with IDD, but wanted to. And we were like, yeah, that makes sense,
Yeah,
right? So,
definitely.
I mean, the only place that might go a little bit south is with our data collection with the claims, because we're trying to look at people, who have IDD in their practice, and then, before and after the echo.
weed
But
goes out.
we decided it would be better to have some missing data there and still be able to build capacity. And I wanted to just say that polling families and getting family input. I mean, that may be something that we do in cohort 2. That's the beauty of doing this twice is, if everything goes swimmingly and we're looking for something else to add on in the second iteration of this next year, I mean, that may be something that we can even incorporate in this project in a small
Yeah.
way.
And it might be worthwhile, one of your concerns was kind of putting that pressure on the clinician. Maybe in that first cohort, you could evaluate that, as part of some of the things that you're asking them about. Do you have anything in your practice now that gives you that feedback? Is that something you would want?
That's a great point. Yeah. Yeah.
Yeah, I like the
this is
idea that they
wonderful.
might actually, some of them may become so comfortable after 2 sessions through the echo, they might feel good about that feedback. They might feel pretty positive that they're going to get good feedback. So uh, it would be nice to know that.
Yeah, that's a great point. Yeah, thank you for these wonderful suggestions.
Well, I love hearing about providers that are actually kind of looking at this and saying, I need knowledge here because we're on the other side with, people that we serve and families that are every day kind of going, they're not giving me what I need, or we're not getting resources we need. So I love this idea and this project. It's great to hear about it.
Thank you.
Can I jump in with a couple of thoughts here?
Please, Janet.
First of all, one of the, I think, motivating factors for AmeriGroup, honestly, is because TennCare has moved the employment and community first choices into their realm instead of just being the 1915C fee for service waivers that were paid for by TennCare, but didn't involve the MCOs in a direct way. They're now seeing the people they support through ECF choices need this help. And so they've got a vested interest, so to speak, to make sure that the people who are getting ECF choices care also get good health care, because it betters their bottom line ultimately, to make sure that the people they're supporting long-term supports and services also get appropriate health care. And when the monetary incentives and the doing good stuff incentives line up, that always
Values.
makes
The values, Jan.
always makes me happy. But the reality is, and everybody on this group may know this, but first of all, most clinicians don't get any training in dealing with intellectual and developmental disabilities. So, if they've never encountered, they don't have a sibling, they don't have a son or a daughter or an aunt, or they didn't go to school with kids with disabilities, it can be scary dealing with folks if you don't feel like you've had any training in how to serve these patients, and you don't have any personal knowledge. It can be scary. It's also often costly because our folks generally take longer. They have more complex conditions. They may not communicate appropriately. They may tear up your office while they're there. So there is an incentive not to take on these patients because you may lose money. And honestly, TennCare doesn't reimburse at the same rate that private insurance does. So people are already taking a financial hit by accepting our folks if they're on TennCare. So there are a number of barriers to doing this. And honestly, those folks that step up to the plate and say, yeah, I'll serve folks on TennCare who have intellectual and developmental disabilities, then they find people like me saying, oh, you should go see Josh Smith, or you should go see Evelyn Watson, because they know what they're doing. Well, then they get inundated. If you build it, they will come. So our hope is we will build it all across the state, and there will be plenty of places for people to come to get appropriate and adequate and
Yeah, that's
hopefully
a great point, Janet. Although I
caring
will
care.
say that some of them, are already seeing folks with IDD and they just want to do a better job. There's so many now. I mean, just take autism, for example, all those kids, the prevalence in 8-year-olds is 1 in 36. So these kids are growing up and they're part of everyday practice. And someone needs to be able to help care for them. So I feel like they're already out there, and it's more of where can I find the resources? Where can I be less isolated? How can I connect with psychiatrists, right? And behavioral health people who can help me. So I do feel that part of it is they may not want to take on more, but a lot of it is it's out there already and they just want to do a better job and feel less isolated and feel like it's, fun as
Yeah.
opposed to a burden.
Yeah, I agree. I mean,
Fun-
I think there's clinicians out there that want to enhance their practices, and that is definitely something we want to support, right? But I think there is still, like Janet's referencing, there is a group still that, we have to do the work around educating and capacity building to destigmatize the population, to humanize them as much as we shouldn't have to do that. I think we have to do that on some level because when you don't have that understanding, that training, and that, they are humans first, right? Like if you don't have that, like we have to help break that down as a barrier because it's definitely something that impacts, everybody and the care.
Yeah.
Well, there
No,
has
I
been
agree.
research done that many medical professionals have ableist attitudes because they think, oh, if I had to live my life like that person lives their life, they don't have a quality of life. And so they don't value the care and the treatments and such in the same way as they do. And I didn't even know there was such a word as ableism or ableist until probably about 5 years ago.
Yeah.
But I will search right quick and find. Now this study is broader. It's not just intellectual and developmental disabilities. It's disabilities in
All
general.
disabilities,
But
yeah.
it found a significant number of medical professionals, and they did 8 different, like primary care, OBGYNs, I forgot who all else, but so they took a broad, it's very broad, but it's not very deep. But they found ableist attitudes, and they did find women were
Definitely.
more
Yeah.
willing to serve people with disabilities than the men were. But I'll find that and I'll drop that in the chat box. And
Yeah, and I was gonna say for people in the audience, if you're not familiar with ableism, 100% recommend you look it up. For yourself, even for your own ways of thinking, to monitor your own biases. I mean, it's super critical and important. And there's a lot of really good resources out there.
And the other thing I was going to say is, if you can't tell, Beth is the eternal optimist and Janet's the eternal pessimist. So I always bring up all the negatives and all the barriers.
Oh,
And,
you're good.
and Beth is
I'm a
really
good
the
balance.
only
I have a good
Listen,
balance
let
of
me-
both most of the time.
Let me get us back on track then, Janet, and do some friendly, playful jousting here. Babs just put in the chat our brochure. If you are interested, based on what you heard today, and you are someone who accepts AmeriGroup insurance, and you can make those September times that I mentioned, the first and third Thursday of the month, or most of them. It's a 6-month program so there's a total of 12 sessions, the first and third Thursdays of the month, from 12 to 1 Central. AmeriGroup provider, someone who would like to increase your knowledge of caring for adults with IDD. By all means, reach out to us. The email is very simple. It's in the brochure. And then the other is, if you know of someone or a group, I think we've gotten the word out to many different groups in Tennessee who are affiliated with clinicians who care for adults with IDD, but if you know of a clinician, if you know of a group that we haven't reached out to yet, by all means, feel free to share the brochure with them. And we want to try to get that, we're at 12 now. We want to try to get to 25 by September, and we still have to consent. So, it takes a little bit of time to do all that, but we would love to have any of you help us out in either of those two capacities.
Yeah, hopefully there's some people on that are interested in joining it themselves, and maybe some people with lived experiences or family members with lived experiences that have a physician and they're like, hey, this is something you could you could do. So I hope this helps to boost your numbers.
Yeah, the Project
presentation for
Echo
sure.
at vumc.org is now in the chat. So feel free to you just email us, and Sally and her colleagues, man or woman, that that email, and we'll get back to you and let you know next steps.
Might be worthwhile on the more mental health clinician side. I don't know if you've already sent this out to TAMHO contacts, but they had a lot of psychologists that they've reported to me are wanting more information on this population. So if you haven't reached out to them, let me know. I'll connect you. But that would be an
I don't
area.
think we have. I don't think we've reached out to Tampa. That would be great, Michelle. If you could connect us, that would be great. You can just email me and I'll get it out to my colleagues, and we'll get, or just share the flyer would be the other way to do it. And then if they have questions, they can reach out to me.
Yeah, I'll do that because they were looking, I mean, they're psychologists, social workers. It's the Tennessee Association for Mental Health Organizations. For
That'd be
you
great.
don't know who TAMHO means.
We just got our we just got our APA credit approved. So we now have continuing education credit for psychologists.
Yeah, I'll send the flyer over to my contact at TAMHO and hopefully they can get it out to their members.
Wonderful. Thank you.
Does anyone else, I mean, we've got, several people on here. If anybody else has questions or comments for Dr. Malow or her team, you can pop them in the chat or you can unmute and ask. I'm gonna give people an opportunity. I don't like the weird silence, so I always try to fill it. But
well, I'll say one other thing, which is we're also going beyond the clinicians. So if they want to bring nurses with them or whatever, they can come on the Echo as observers with their cameras off. The reason we're limiting the camera on it is, as you can see right here, 25 is like the optimal number on Zoom to get everybody on the square, so to speak. When you go beyond that, you start moving on to other squares. So observers, we can take even more. And anyone who wants to observe, we just ask that you have someone in your practice join the Echo as camera on billing clinician, and then affiliated with AmeriGroup, and then we can have them bring as many observers as they want.
Because we want to share the information, but the folks that we really want to engage in the back and forth, the case presentations, are those primary providers or those clinicians that are the billing providers who are sort of the gatekeepers. It's great if their nursing staff knows what's being said and going on and how the cases are presented and even the didactic information. But the folks we really want to get in with and engage and create a community of practice are those clinicians. It's not that we don't like nurses or office staff, but many of you know Dr. Tom Cheatham, who passed away several years ago, who was a dear, dear friend and instrumental in me being able to do what I do today. Felt like the conversation just changes when you have office staff or nursing staff and not the clinicians that are actually seeing the patients and prescribing and making decisions about what screenings or testing needs to be done. So we defer to Tom's wisdom on this. So we have lots of lurkers, as we call them. They can sit in and listen, but they keep their cameras off, and they don't engage in the conversation. So
Yeah, and we might have,
Observers is
we may
definitely
have
a nicer
spinoff.
term for that.
Yeah, we may have a spinoff down the road where they don't have to be considered lurkers anymore. They'll have their own echo, just like family members have their own echoes now. So, but
Yeah, especially
so,
like
you know, we want
nursing
to be
and,
careful.
and office
Yeah.
staff. I mean, they need the same,
Right.
you know, they need the same education. So I appreciate that you guys, you know, make it beyond the amount that you're able to kind of get on camera and engage. That's really, a really good thing.
It's
So,
tricky. I mean, I think I was recently participated in an echo on COVID, and community health workers were included as well as clinicians, and it created kind of a weird power dynamic. So I think that being careful, even though we have a desire to want to train everyone, like keeping it more focused sometimes is the right decision, and then kind of expanding it out over time or finding different groups that can have their own echo, I think is good over time. But
one of the things we try to do to level the playing field is we intentionally don't use doctor.
mhm. Yeah,
It's Beth and Gary
Yeah.
and Mavra and Josh and Janet and Linda.
yeah,
And because just by virtue of using that doctor, you have unleveled the playing field
sure.
to the nurse practitioners, to the physician assistants, to the social workers.
Yeah.
Absolutely.
Agreed.
Yeah, it's a very democratized type of learning. You know, we truly want to have a learning community where everybody feels their voice is heard, it's similar, and also that no question is, you know, silly or
It's silly.
whatever.
Yeah,
Yeah.
definitely.
Yeah.
Well, I think the program is great. Big fan of echoes that you guys have done. And I'm very hopeful for this one, and I hope maybe you'll consider coming back and sharing your results, especially of that data of the impact on the people receiving services. That would be really cool to see. But
Absolutely. Yeah, no, we would love that. And in the meantime, feel free to look at the paper that somebody, I think, circulated that we literally just saw in print this morning. It was accepted a few weeks ago on our National Department of Defense Autism Adult Echo, but it's now officially out there. So feel free to look at that in the meantime.
yeah, that's awesome. Well, thank you all for being here today. We're officially at the end time for the Clinical Consultation Network. So you guys did a great job filling the hour without the smarticle or the intro. So really appreciate you taking the time, sharing this valuable information, all the work that you guys do to expand and build capacity of the system as a whole. Just truly appreciate all of that. But we will see everybody next week for the Clinical Consultation Network on Tuesday at 12:30. So have a great rest of your day, everybody. And we'll see you next week. And hopefully Dr. Davis will be back. Bye, all.
Thank you all.
Bye-bye.
Bye.